Hello, everybody, and welcome to today's webinar, The Body-Eye Connection with Dr. Alon Harris. My name is Elena Sturman. I am the President and CEO of the Glaucoma Foundation. The Glaucoma Foundation has been raising awareness, supporting and identifying innovative research, and providing education for patients and their families since our inception in 1984, almost 40 years ago. Our goal is to improve the lives of patients with glaucoma and ultimately find the cure. This is our fourth webinar of 2023, and we are very excited to have Dr. Alon Harris with us today. And he will discuss with us how systemic blood pressure is related to glaucoma, what effect blood pressure medications have on intraocular pressure, and how artificial intelligence and mathematical models help in related research. Professor Harris is a professor of ophthalmology, vice chair of international research and academic affairs, and director of ophthalmic vascular diagnostic and research program at Mount Sinai Hospital, Icahn School of Medicine at Mount Sinai Department of Ophthalmology. Dr. Harris is also a member of the Glaucoma Foundation Board of Directors and Scientific Advisory Board. An internationally recognized expert and leader in the field of ocular blood flow and glaucoma, Dr. Harris has received more than $6 million in research funds from prestigious institutions such as NIH and NEI. He has served as principal investigator on dozens of industry-sponsored clinical trials and has published hundreds of peer-reviewed journal articles, 22 books, and 60 book chapters, garnering many national and international awards. He holds several patents in the US and is world-renowned as entrepreneur in the field of ophthalmology, with extensive experience in bridging the translation from academic discovery to marketplace solutions. Today, we have truly international audience for this webinar. People from all over the world have joined us. We are so grateful to have all of you. As always, there will be a question and answer session after the presentation. You can ask your question by using a chat button or Q&A button, and we will do our best to answer as many as possible. One small request: if you're asking a question from outside of the US, please identify the country of origin you're asking the question from. Today's webinar is sponsored by Santen. We are so grateful for Santen's incredible vision to support patient education and for our great partnership. Now, ladies and gentlemen, please welcome Dr. Alon Harris, and let's begin.
Thank you very much, Elena, for this very kind introduction. It's an honor to be here and to present to people and patients, glaucoma patients worldwide. I'm also very proud to be part of the Glaucoma Foundation, a non-for-profit organization that does terrific things for patients and researchers alike worldwide. I'm going to talk about the relationship between the body and the eye. We tend to think about the eye and diseases of the eye localized in the eye itself, but I will show you today, hopefully, that the eye is rarely influenced and impacted by what's happening in the body. These are my financial disclosures, none of which are directly related to this talk. And we've been supported for these studies, as Elena said, by the NSF, National Science Foundation, NIH, as well as other organizations. This is the team. It's a multidisciplinary approach with many people around the globe that have invested time and efforts in this. People that are highlighted here from my team, Dr. Saiski, Berticchio, Antman, Keller, as well as other people like Giovanna Gudebani and Julia Siero have all been instrumental for these studies. Next slide, please. Today, basically, I would like to present research and new scientific data for you, the glaucoma patients. The program is intended for educational purposes only and is not intended to provide any clinical advice. I would like to basically set the stage to this talk and mention that we will be dealing with a set of pressures in this talk, not only coming from the eye. One set of pressure for the eye, or the intraocular pressure, is the pressure that is in the front part of the eye and can compress all the way to the back of the eye, will be dealt with and is familiar to glaucoma patients. But we will also be dealing with blood pressure as well as brain pressure. I'd like to give you a background, epidemiological background, and define the disease basically quickly for you. We're talking about an estimated 57.5 million people worldwide that are affected for glaucoma, with a global prevalence of 2.2%. Worldwide, the number of patients with glaucoma is expected to increase over 111 million by 2040. So glaucoma costs in the US economy is over 2.8 billion every year, indirect costs and productivity losses. So this is a major burden and a major issue that we want to deal with in taking care of patients' eyes. What is glaucoma? Glaucoma is a chronic disease, a progressive disease of the optic nerve and related structures in adults, where there's acquired atrophy, loss of nerves in the optic nerve and retinal cells called ganglion cells, as well as their axons. It's a potentially blinding disease, but early diagnosis and treatment can generally prevent visual disability. My key message at this point about the definition of the disease is that the definition of glaucoma, primary open-angle glaucoma, is not synonymous or solely defined by the presence of elevated pressure inside of the eye. This is what happens when you have glaucoma. The images on top are from a normal eye, normal person. You can see the optic nerve on the left and the vessels that supply it, and you can see the picture of the image sensed by the patient. You can see on the lower image or drawing that there is this yellowish area, like the hole in the donut, if you will. And this is where we have lost nerve cells, lost nerve tissue due to glaucoma. And you can see that the vision has narrowed up to tunnel vision. Next slide. Here I've listed for you the many different risk factors that are actually important in the development and progression of glaucoma. IOP, the pressure inside the eye, intraocular pressure, is the only one approved by the regulatory agencies for treating glaucoma. As we lower that pressure, we can help patients and prevent for more progression. Other factors related to age, it's more prevalent in African descent patients, family history, genetics, myopia, thin corneas are all important factors. On the vascular side, though, I've listed blood pressure, migraines, disc hemorrhages, nocturnal or shifts in blood pressure at night, low perfusion pressure, which we will be defining in a moment, diabetes, and impaired blood flow, or the regulation of blood flow to the nerve and the neural tissue. And here are the factors that we will be focusing today and trying to look at this puzzle in glaucoma related to all these different pressures: intraocular pressure, blood pressure, changes in blood pressure at night, and impaired blood flow. Historically, we know that the vascular risk factors in glaucoma have been mentioned already in 1800, and later on they've been suggested to cause or to be related to the disease, although all these years we practice the disease only by lowering pressure. So what have we done since the days of Priestley Smith and others? We've expanded our toolbox, and I'm here to give you this new information. We're using population-based studies, epidemiology. We're using advanced imaging tools like OCT and OCTA. We're employing mathematical models and artificial intelligence. I want to briefly set the stage for you so this talk becomes a bit easier to understand and clearer. Let's look at the relevant anatomy. What we can see here is that the intraocular pressure, which is the big instigator in glaucoma, is determined by the balance between the secretion of this clear fluid, which is different than blood pressure, called aqueous humor, is important to nourish the lens and the cornea, as well as other function. And basically, it drains through two independent pathways that you can see: the trabecular meshwork, as well as a different pathway, the uvus sclera, and then into the lymphatic system. Just like at home with your tap and the faucet, when there's an imbalance, basically that pressure is going to rise and is going to compress on different structures in the eye, including the nerve cells in the back of the eye, and lead to damage. But what is also important, like with any system organ, is the blood supply to that eye to bring in oxygen and to carry out the byproducts of metabolism. And here you can see very nicely this long rope-like structure is the optic nerve that carries the information from the eye to the brain after it was converted essentially from light energy to chemical energy and carried to the back of the eye. You can see that that nerve is heavily vascularized with different blood vessels, and these are superficial and deeper blood vessels that can also impact on the health of the nerve tissue in the back of the eye. One more definition as we move along, setting out players for the game we're going to talk about in looking at these different pressures. The endothelial cells. The endothelium is a monolayer single cell of an endothelium constitutes of intercellular lining of the vessels like the arteries, the veins, the capillaries, and they play an important role also when they when they basically don't function well. We have a problem in dilating these vessels to bring in more blood or constricting against high pressure, and they can interfere with regulation or autoregulation. Galileo says, measure what is measurable and make measurable what is not. Basically, this is another way to show you and share with you the impressive toolbox that we have developed all these years together with others. And I want to share some of these devices with you. Here you can see different types of devices and methodology for imaging the back of the eye. We don't have time to get into them in detail, but you can see that they range from different type of techniques like OCT, optical coherence tomography, optical coherence tomography angiography, which is the one that you can see here on the left side of this slide. You can see Doppler signals coming out of the eye. You can see on the top oximetry, the measurement of oxygen saturation, which is ultimately being looked and investigated in glaucoma patients as well. Here is an example of what this flow of blood looks like, and I need to impress on you how impressive this image is. The shadow that you can see in the center is actually that same rope, that same optic nerve that we've seen previously in the anatomy. And you can see that it's vascularized by the red, which is the arterial blood, and the blue is the venous blood, which drains that. I'm going to run that again. And you can see that the optic nerve is nourished by these blood vessels. Essentially, I have devoted a career to try and understand the impact of the blood supply to that nerve, to the surrounding nerve tissue, and how it can impact on different eye disease. So when we talk about evidence in medicine, when we talk about rigorous evaluation of the consequences of clinical actions, we mean partly studies that looked at thousands of subjects. Because if I'm going to do a study on one or two individuals, this may not have an important impact on the entire population. So that's really important in understanding the impact of the different risk factors. Here you can see that based on these large-scale population-based studies, it's definitely being concluded that it's justified to lower IOP for the treatment of glaucoma. There's many studies that are listed in the literature. As you lower intraocular pressure, you definitely slow down the progression of this disease. You can see this in different studies, but you can also see that a subset of these patients, between 5 to 45%, depending on the study and the paper that you read, continue to progress in this disease. That only supports the fact that there's other risk factors that are contributing to the disease that are different from intraocular pressure, like we have discussed, and we're going to continue to discuss them. The first one is the perfusion pressure to the eye. What is perfusion pressure to the eye, and why do I want to define it? I want to define it because there's been many studies in glaucoma that suggest that this pressure, when it's low, can cause glaucoma, can worsen progression, and can lead to the conversion of patients that are at risk of glaucoma, called incidents, to become glaucomatous patients. So what is it? The eye is very unique in that the pressure in the veins must be equal or exceed this pressure in the eye called intraocular pressure just before exiting the eye to prevent collapse. The difference between the blood pressure and the intraocular pressure is the perfusion pressure that is so important to maintain the adequate nourishment of oxygen, of nutrients to the eye. So for perfusion pressure in the eye, the difference is blood pressure and intraocular pressure. Now that we've set the stage, I can tell you that perfusion pressure was being shown to be an important factor for the prevalence of the disease. The proportion of people in a population who have a particular disease or attribute at a specified point in time over a specified period of time. I will also show you that it's important for incidence, the correct definition, the occurrence of new cases of disease or injury in a population over a specified period of time. And it's been shown to be related to progression. The top image on the right is a normal eye. You can see that the whole of that bagel, of that optic nerve, of the donut, is smaller, that yellowish area. It means we lost less nerve tissue. And the vision that is shown on the eye by looking at psychophysical testing, visual testing of how you see, is normal. Below it is some damage to glaucoma with more damage to the optic nerve and worse vision. And then the third one is when we have progressed disease. It's been shown that the perfusion pressure can also impact progression. But since I come from a hard science background, I have to show you this. This is from one study called the Baltimore Eye Study. As that perfusion pressure, which I defined for you before, is lowered, the prevalence of the disease, those numbers saying glaucoma risk, are increasing. To make it more practical, or sound in more practical terms, some of you in the audience will have diastolic perfusion pressure that are less than 50. It doesn't mean that you will necessarily have glaucoma, but it means that it could put you in additional risk. Likewise here, you can see from other large-scale studies, many studies, that as the perfusion pressure is lowered on the X going to the left, the prevalence of the disease is increased. And we see this in, as I said before, supporting studies that show it both for incidence and progression. So, low perfusion pressure then, the difference between the pressure of the holes, if you will, to the eye and the intraocular pressure is an important factor to prevalence, incidence, and progression of this disease. As I've shown you, the idea that the blood supply in the vascular system is important in glaucoma was suggested way before I came to this world and other smarter people than I did. But it was only in 2009 that Bob Weinrep and myself published the book after and following a consensus meeting of many leaders in the field that suggested that low perfusion pressure can be considered an independent risk factor for glaucoma based on many population-based studies, and that's why I defined evidence-based medicine for you before. Now I want to look and see what can we say about blood pressure and its effect in glaucoma in terms of its mechanism, and also does high blood pressure play a role? We spoke about low perfusion pressure. So here you can see a bit of the mechanism. Hypotension, meaning low blood pressure, leads to a situation where this occurs and can occur at night. It causes choroidal, which is the name of the blood vessels that bring in the most blood into the eye. It's like a sea of blood there coming into the eye, that there are some microvasculature dropout of these vessels, and this could be related to glaucoma. So here it is. This looks complicated, but it's not. On the left is the eye pressure, and on the right is blood pressure against time of day. The top graph, the black one, shows you that blood pressure dips at night, both for the diastolic and the systolic, which is the low pressure. But at that time, when blood pressure is low, the intraocular pressure can be high because it tends to go up at night. That means, and if you were next to me, I would ask you that question, and I'm sure you know the answer, that at night we could have situations of low perfusion pressure. So while we're sleeping, the disease and the instigators may continue to cause some damage. Now, normally it's regulated, there's autoregulation that comes in and fixes that and makes sure that we dilate with the vessels. But remember, if the endothelial are dysfunctional, as we define them, like was reported in the case of glaucoma in some studies, then there's no ability, or the ability to maintain this blood flow can be compromised. Here are studies, just to support what I say, that suggest that when baseline ophthalmological studies are performed together with blood pressure monitoring studies, they concluded that dips, lowering of blood pressure, are important in the 24-hour blood pressure monitoring and associated with increased risk of glaucoma. And this was just published in 2022. Here is basically what I've described to you in words before. It shows you autoregulation, the intrinsic ability of a vascular bed to maintain blood flow despite the changes in perfusion pressure. And failure of stable blood flow regulation may lead to ischemic damage of the optic nerve and the ganglion cells, leading to glaucoma, the nerve cells in the back of the eye, in the retina. Okay, so I hope all these terms are coming together slowly. What about high blood pressure? We discussed low blood pressure, low perfusion pressure. And here it's interesting. First of all, you should be aware of the definitions. Today, there's very aggressive definition of high blood pressure. In fact, elevated is already over 120. When it's to 129, this is elevated blood pressure. Stage 1 hypertension is over 130, or 1 on the diastolic 80 to 89, and stage 2 is over 140 over 90. An estimated 1.28 billion adults aged 30 to 79 worldwide have hypertension. And so we can't really ignore this and how it may be related to glaucoma. Again, I come from a hardcore scientific background to have support for statements that I give. I don't want you to be bothered with the details in this slide, but to tell you it's a meta-analysis. It means that it took many different published papers and concluded that hypertension was an important risk factor for glaucoma in these studies. I do want to mention that it takes a large elevation of blood pressure relatively to see the change in intraocular pressure. And so sometimes there could be a controversy as to how important the hypertension is. Relative to the hypertension, we definitely have stronger data for the lower perfusion pressure and the hypertension, but it does play a role. Here's an example. Again, on the top, you can see images from a technology that images the back of the eye. It's unbelievable ability down to micrometers. And you can see blood vessels that are arranged around the area called the fovea, the center of your vision. This is where you get the sharpest vision from, in that area, in the back of the eye, okay, in the retina. The top one is from a healthy individual. And you can see the arrangement of the blood vessels are normal, as well as that yellowish area on the one on the right. And that is called the fovea avascular zone. On the patient that we've got below, E, F, and G, it's a patient with hypertension, 64 years of age, that has elevated blood pressure for over 10 years. And you can see that there are areas of dark, areas of capillary and vessel dropout, vessel density, and what we call PD, perfusion density, which are measures of the function of these blood vessels, are less than compared to the other individual. And the foveal avascular zone, the area that is non-perfused in the center of the vision, is higher. Not only that, the pizza diagrams on your right shows you the structure. It's another measure through OCT, another, if you will, taking an image of the back of the eye. The green is normal, and it shows you that the inferior part in these patients, the red more than the yellow, meaning damage to the nerves in the back of the eye, to the nerve fiber layer, to the nerve fiber thickness, has occurred, and it's associated with these blood vessel changes. And I've already discussed the mechanism as a physiologist. We find that in glaucoma, some patients can have endothelial dysfunction that causes or is characterized by imbalance between the ability to dilate and to constrict. And the occurrence of these endothelial dysfunction disrupts the barrier of the permeability that is part of an inflammatory response in the development of cardiovascular disease in general. So we see that high blood pressure, and that makes totally intuitive sense, it's true in diabetes as well, can cause these blood vessel damage or changes, which I've showed you in the previous chapter. And now the question, can high blood pressure be related to intraocular pressure? And as I said, it takes large changes in pressure to see changes in IOP, but the answer is yes. And you see again, I rely on many different published papers and investigations, and the majority show that there is a relationship such that as hypertension increases, there is an increase in intraocular pressure. Again, takes relatively large changes in blood pressure to see the changes in intraocular pressure. How and why? We think that high blood pressure can increase the pressure in the eye by increasing the production of the aqueous humor. Remember that guy in the beginning of the talk that I've defined for you? The fluid that is produced in the ciliary body in front of the eye and is clear and nourishes some parts of the areas that are not vascularized and has other function. It needs to clear the eye. And we think that that production can be changed, can increase it and cause an imbalance between the production and the clearance. Or it can decrease the clearance of the aqueous flow. So raised intraocular pressure in pink can cause and compress the back of the eye, cause what we call mechanical pressure and or ischemia that we've seen. We've seen dropout of blood vessels, okay? All of this that can also compress on the blood vessels, and that could contribute to glaucoma. So now the plot thickens. We dealt with blood pressure, but there's another player, and that's your brain pressure. Sorry that this is complex, but the human body is a terrific machinery that is very smart and very complex. Defining briefly, the back of the eye, you can see the blue structure is the optic nerve head. And the back of it is the basically points towards the brain. The two different fluid-like looking areas are basically the cerebral spinal fluid, the fluid of the brain, and it obviously has a pressure. It's called the cerebral spinal fluid pressure. Now, when blood pressure is normal, when blood pressure is elevated, the cerebral spinal fluid pressure tends to be higher to prevent bleeding. When blood pressure is low, which you can see on the left side, it tends to be low to maintain normal perfusion. So the difference between the pressure in the eye and the pressure in the brain may play a factor in glaucoma. Forgive the fancy words, translaminar cribosa pressure. It's the pressure between the two sides of the nerve, the one closer on the eye side and the one closer to the brain side, and that difference can play a role. And I will show you. This is like these two pressures, the eye pressure from the one side, the brain pressure from the other side, and the pressure gradient across the optic nerve structure called the lamina cribosa is important. And when the intracranial pressure is low, it favors, when the blue is low, it favors more action of the red, and that can cause damage due to the effects of intraocular pressure on the nerve tissue in the back of the eye. And here are studies. Again, I will always support these. This is a large retrospective study that suggested that in patients that had normal pressure, but still had glaucoma, in their case, they feel that the cause could have been the low cerebral spinal fluid pressure or the brain pressure, because under normal intraocular pressure and lower brain pressure, it will favor more of an impact on the of the intraocular pressure, as we've seen before. This is just to tell you that we have ongoing studies where this is studies in Lithuania that we've been doing, where we actually measure or we estimate the intracranial pressure using this device in a non-invasive way, so we don't need to use electrodes position in the brain, and we can then make important statements about glaucoma patients. And early data suggests that in normal tension glaucoma, there is a lower intracranial pressure that we can detect sometimes in these patients. The last chapter, I'm trying to bring it together for you. How do changes in intraocular pressure and blood pressure that we have discussed ultimately affect the blood flow to the eye, which is part of the blood flow is affected by the perfusion pressure, and glaucoma prevalence and progression, which we have defined before. For that, we've expanded our tools. I won't make it complicated. I will just let you know that we have employed mathematical modeling, and that is because that the observations that we've used until now, the individual observation, the population-based studies and clinical studies, many times have different confounding issues. Okay, for example, it's difficult to isolate all factors that are affecting perfusion pressure. So we try to create a virtual lab and simulate the situation. And that's what we do with the modeling. And I don't want you to get into details, but just to state some basic facts, that the model is basically calculates the blood flow that runs through the blood vessels in a similar way, leveraging on the analogy between blood flowing in a network of vessels and current flowing in an electrical circuit. And that allows us to then create simulation. Is the autoregulation, the maintenance of blood flow normal? Do we see any problems on the venous side, like venous collapse? And we can take that into account. We also combining it more recently with our newer toolbox, basically with artificial intelligence. And this is something that everybody uses and everybody states lately. And, you know, we'll keep the definition here quite simple and straightforward. Intelligence demonstrated by machines as opposed to intelligence of humans. Example tasks, which you may be familiar with, include speech recognition, computer vision, translation between languages, as well as other mapping of inputs. And it's very popular today. And it affects many different areas of our lives. So what I will show you here, for example, is a terrific example with a study that I've done with Lou Pasquale in Mount Sinai Hospital and Dr. Brown. I want to give them credit. And basically, we are looking, we've taught the machine to detect these bleeding called disc hemorrhages in the back of the eye. And basically, these disc hemorrhages can be considered to be like microinfarction in the optic nerve bed or perturbation of the blood-retinal barrier, many little type of these infarctions. And why are they important? Because they have been shown in glaucoma, these small little bleedings in the optic nerves, these disc hemorrhages, to be associated with the progression of glaucoma. And if that's why glaucoma specialists many times try to look for them and detect them. So here is an example of a study that we have published parts of it before, but presented it now, just sent it off, and it was accepted in ARVO, the big research meeting worldwide. And basically, you can see the system architecture on the left. The input is from photographing the back of the eye. It comprises basically three primary components. The first one, the A, basically learning the critical images features from the input of those photographs that are taken, okay? Then the image is basically in B, features undergo aggregation of the different photos that we have, and that's followed by prediction of boxes and confidence scores. And in simple word, it means that the machine has learned by reviewing many of these photos and by defining what these bleeding and disc hemorrhages are, the machine now is capable of detecting them. And we can see on the top left, these boxes show us in the back of the eye, the optic nerve, that basically the area that we are measuring is very close to the optic nerve, and those boxes show us that the ophthalmologist has pointed those areas as microinfarction, bleeding disc hemorrhages. The one on the right shows you that the machine has been successful by itself in detecting it. Below, again, the left shows you in C, shows you the box in green, shows you that the doctor managed to detect it, but actually the machine in this particular case is capable of detecting multiple hemorrhages in the same image, and the model recognizes basically the hemorrhages that were not labeled by the grader. Overall, we have developed an artificial intelligence method to pinpoint hemorrhages in the optic disc photographs on par with trained ophthalmologists. And we've also employed the mathematical model and the machine learning in a different way. basically what you can see on your left is the plotting on the X of the eye pressure against, on the Y, the blood pressure. This is taken from a study that I've done in Indianapolis with my team called the IGPS, the Indianapolis Progression Study, and these are baseline data. Look at these plots. Look at this plot. Can you tell something from it? All the patients seem to behave normally when you look at the relationship between the eye pressure and the blood pressure and what it means for hemodynamics or blood flow. But, and I will save you all the details, when we run this data through the combination of the mathematical model and this machine learning, in this case, it's a bit different. It's called unsupervised machine learning model, fuzzy Siemens clustering algorithm. Suddenly, we see patterns of these clusters. And each pattern has has characteristics. And suddenly, the patients are not all the same. For example, if you look, the green ones are patients that had problems with regulation of blood flow based on the model, okay? Other groups may show that they have higher venous pressure based on these combination. And what we have when we look at Mr. Smith, we're hoping by being able to know where his specific data related to blood pressure and eye pressure falls based on these clusters and based on studies that we have used to validate our data, we believe that we're looking towards our ability, and we published this, to be able to take measurements of blood pressure and IOP, eye pressure, and to hopefully predict how these patients are going to progress in the future. Disclaimer, this is new research, this is being investigated, this needs to be fully validated, but this shows you what we have been busy with over 3 decades in trying to understand and using the different toolbox that we have, where Mr. Smith is today, and based on relatively simple measures, try to predict. Why? Because not all patients worldwide are fortunate to have what we have in the US and other developed countries, and it might be difficult to image their eyes. It might be difficult for them to have actually access to diagnosis of glaucoma. Some of the population-based studies that I'm part of show that 40% of glaucoma patients are undiagnosed. So, artificial intelligence and mathematical models may enable individualized glaucoma management and treatment across population, hopefully in the future. But you're asking me about today. And relative to the talk that I gave about heavily weighted towards blood pressure, what can Mr. Smith do today? Wow. We know that these factors actually can impact blood pressure. Exercise, smoking, drinking, and of course, medication. So regular physical activity is associated with lowering blood pressure, reducing cardiovascular risk factor, and reduce cardiac remodeling. There's one answer for you that is sort of a low-hanging fruit before you get into all the sophisticated data that you can help yourself with. How about smoking? Smoking and the risk of glaucoma is a bit more complex and a bit uncertain. Some studies suggest no association or even a protective effect when acutely, because that might be for acute vasodilation, dilating the vessels, and other studies link smoking as increased risk of onset and progression. I'll let you choose. Alcohol, about half of the studies reported an association with high intraocular pressure and prevalence of high eye pressure. and a positive association between any use of alcohol and glaucoma. So there's some evidence, but it's not as strong. So all in all, basically we seeing that anything that the eye pressure or that glaucoma is not isolated, it's connected to the entire body, and that makes absolutely sense, I hope, to you more now than before. In summary, Leonardo da Vinci says, the eye, which is said to be the window of the soul, is the principal means by which the sensory world is apprehended. It is by this that colors and shapes are distinguished, and it is through the eye that their influence penetrates to the soul. Thank you very much.
Thank you so much, Dr. Harris, for this fantastic presentation. I'm sure the audience that is with us today really appreciated it. And they've been writing a lot of questions, and we have a little bit of time to address those questions. So let me give you a few of them. Question number one, is it true that certain hypertension medication can exacerbate glaucoma? And if it's so, could you identify these medications?
That's a great question. And obviously the person that asked the question has followed what was going on in the lecture, in the sense that it's not a yes, no, and what. It's a bit complex, and I will try and simplify it. So first of all, again, I come from the background of presenting the facts from studies when I answer these questions. I was a principal investigator of a big population-based study in Greece called the Saloniki Eye Study, which is ongoing since 1999. The Saloniki Eye Study, as well as other studies like EGPS, the European Glaucoma Progression Study, have shown, to answer that question, that the combination of medications to lower blood pressure and the low perfusion pressure, or the low blood pressure, under those combinations of circumstances was actually related to damage that we see in the optic nerve, like in glaucoma. And then there were two studies, 2006, 2013, and they were both supportive of that. There are other studies like the European Glaucoma Progression Study that show that diuretics and other antihypertensive medications were associated with higher risk in glaucoma. Now, just a bit mechanistically, from a physiology perspective, what can happen here? So you now, the audience, and thanks for listening, by the way, and being patient with me with the definitions, have the tools in the toolbox to follow this explanation. As we lower blood pressure, we lower perfusion pressure. So if it's not too low, it should be fine. And I want to also make a disclaimer that for the health of the heart and for our well-being, low blood pressure, if it's not very low, is actually something very good for us. After making this disclaimer, I want to suggest that if you low blood pressure by means of medications and you lack the ability to regulate or to maintain blood flow because of dysfunctional endothelial cells, then what's going to happen is that could lead to conditions of low perfusion, and possibly ischemia, which could further damage those cells. Now, for that, however, that specific individual needs to have altered dysfunctional autoregulation. And it may be or may not be the case. As far as what class of medications or what kind of medications, I've yet, and in the Saloniki study, we couldn't pinpoint specific medications that can be harmful, but we know principally that medications that may have an impact on constricting blood vessels okay, or lowering the perfusion pressure without the ability to auto-regulate may have or may be additional instigators to glaucoma. So this possibly, in this case, if there's a concern, I've heard of cases where there's consultation between the glaucoma specialist and the cardiologist over the blood pressure medications.
Thank you very much. And your last sentence, you actually picked up on the next question asked from Canada. And the question has to do with cardiologists and ophthalmologists. And the question is, how do we get cardiologists and ophthalmologists to coordinate treatment for patients who have both heart issues and glaucoma?
And I think that's a brilliant question again from Canada. Thank you, because basically, as you've seen, especially as it relates to the cardiovascular system, there's no separation between the eye and the brain. The eye is and the body. The eye is an extension, essentially, of the body. And if there are issues with autoregulation or issues with dysfunctional endothelial cells or blood flow or high levels of or atherosclerosis, many times they could appear in the eye and impact the eye as well. So I have been in symposiums, many around the world, where we've had in the last decade or two, where there have been some symposium that have actually, where data was shared between ophthalmologists and cardiologists in terms of the need to have sometimes consultation that actually has the cardiologist be aware of the condition of this glaucoma patient. So if the ophthalmologist considered a vascular or ischemic event that is related to perfusion pressure, that's a good time where consultation might take place.
Thank you very much. Next question. When is it advised for glaucoma patients to have an overnight blood pressure study? And what, if anything, would be gained for the patient by doing so?
Again, I want to, before I answer this, I want to make a disclaimer. So this is not a suggestion. What I'm telling you is basically, several decades of scientific reports and basically listening to practicing ophthalmologists on the topic. So, and I can tell you what makes sense from a scientific background. Having glaucoma, where you can't pinpoint that intraocular pressure is your main instigator, okay? And these other vascular risk factors seem to be in the neighborhood. For example, that you have low blood pressure, that you have low perfusion pressure, that you have disc hemorrhages coming and going back and forth out of your eye, that you have other symptoms that ophthalmologists consider, like I know there was a symposium about vasospasm, cold hands, migraines. These are all examples of what's out there in the literature that could be related to some vascular issue. In those cases where intraocular pressure is normal, but glaucoma still continues to progress, and the ophthalmologist suspects that there might be an issue with blood pressure during the night, that's as a factor. I've seen, a lot of referrals that have been taking place where people have then tried to monitor blood pressure at night to see if there's an exacerbation of these blood pressure dips. And better, but there's very few places in the world that can do it. And, we do it on a scientific basis, actually examine or measure the regulation of blood flow through methodology that we have when I've shown you the toolbox in the beginning of the lecture.
Thank you very much. So next question is very interesting. There are many treatments to control high blood pressure. Are there any drugs or other treatments that may also lower IOP simultaneously, achieving two goals at once?
And that's a great question. Again, I can tell you that, for example, there are classes of medications that we know are used for treating blood pressure, okay, that could possibly also lower the intraocular pressure. For example, beta blockers. There is a treatment of glaucoma for years, for decades, non-selective beta blockers like Timoptic, Betoptic, other drugs that are beta blockers that are actually effective in lowering the intraocular pressure. And then you have classes of beta blockers that are used for systemic hypertension. You know, have there been studies that have clearly suggested, you know, and indicated and have gone through the FDA to actually get indication for both? The answer is not that I know of, but mechanistically, it makes sense.
Thank you very, very much, Dr. Harris. We reached the end of our webinar. I would like to thank Dr. Harris so much for the wonderful presentation. I would like to thank our international audience for joining today. I would like to let you know that this webinar was recorded, and if you'd like to listen to it again, it will be on Glaucoma Foundation's website, www.glaucomafoundation.org, and also on our YouTube channel. I hope you enjoyed it. I hope it was useful to you. We are very grateful for your participation, and please stay connected with us and with the Glaucoma Foundation. Thank you very much.
Thank you.
Bye-bye.